Hello, good afternoon. I'm Dr. Fidel Manalaysay III, and my lecture is about hacks in female urology. So what's female urology? Female urology encompasses urinary incontinence as well as pelvic reconstructive medicine for prolapse. It deals with assessment and treatment of female urological disorders like interstitial cystitis or stress urinary incontinence. The bigger term will be functional urology. It's an overlap between female urology, reconstructive urology, and neurourology. So this is me during my training in South Korea. This is me assisting a pubovaginal sling procedure, an augmentation ileocystoplasty procedure for a resistant interstitial cystitis. And this is my professor, Professor Jang Wang Kim of Severance Hospital in Seoul, South Korea. After my 1 year of training, we had a total of 180 cases, majority of which are laser enucleation of the prostate, sling procedure, and prosthetic artificial sphincter. So for my lecture, I'll be starting with anatomy, followed by evaluation, discussion of female SUI, and then management. We already know that the female pelvis has a bigger inlet than male pelvis. Its shape is wide and round, while in the male, it is said to be heart-shaped and narrow. Also, the pubic arc in the female is wider. This is around more than 80 degrees, while in male is usually narrow, less than 70 degrees. The bigger structures and anatomy in the female helps in accommodating the baby in the normal spontaneous delivery. This is a lateral view of the female pelvis, which shows the relationship of the urogenital organs and the reproductive organs. Other relevant structures in this diagram are pubourethral ligament, which is this one, the uterosacral ligament, this one, pubocervical fascia, and the rectovaginal fascia. According to Petros et al., the integral theory talks about continence, and the most important factors to preserve continence were adequate function of the following: the pubourethral ligament, a suburethral vaginal hammock, and the pubococcygeal muscles. Active closure includes contraction forward of the pubococcygeal muscles, which plus the vagina tightly around the urethra, closing it off and immobilizing it while the bladder is pulled down like an elastic balloon, kicking off and closing off the mid-urethra. So during micturition, the pubococcygeal muscle relaxes like this. This allows the levator plate and the longitudinal muscle of the anus to uninhibitedly pull and opening the bladder base. This is like a funnel, enlarging the urethral outlet. At the same time, this stretching stimulates the nerve endings, activating and reinforcing the micturition reflex. We're going to the second part of our lecture, which is evaluation. It is very important, way back from med school, that history and physical examination is the most important part of the assessment. We should know what's the chief complaint of the patient, which is the most bothersome complaint, and the reason why the patient went to the hospital or the clinic. After which, we determine the history of present illness, specifically eliciting presence of frequency, urgency urinary incontinence, or necturia. In the past medical history, it's important to ask the patient about comorbidities and medications which may affect our present illness and the complaint of the patient. Also, previous history is important to determine if there's a previous link procedure or previous incontinence procedure. So what unique in the female is or are presence of urethral mass, which can be a prolapse or caruncle, vaginal changes like atrophy, discharge, lesions, bulging mass, and we should always elicit an OB or menstrual history. Some tools that can help in the diagnostic process, first of which is Bladder Diary. This is an example of Bladder Diary. I extracted this diagram from the latest edition of Campbell. Bladder Diary is said to be the best non-invasive tool which can document the number of episodes of leaking, the number of pads, times the patient is passing urine, average and maximum voided volume, types and amount of fluid drunk, and presence of urgency and nocturia. Bladder Diary has a self-monitoring effect, which means it enhances patient awareness of drinking and voiding habits, which makes them recognize how their lower urinary tract symptoms may be related to their activities. It is recommended and appropriate to record at least for 3 days, according to the International Continence Society. So this is an example of a bladder diary, a 72-hour bladder chart, specifically or from the recent lecture by Dr. David Bolong. He also emphasizes the importance of taking a bladder diary. Another tool which can help us in the diagnostic process are questionnaires. So what are questionnaires? These are validated set of questions that can measure the severity of a symptom of interest. Example which are IPSS or International Prostate Symptom Score, ICIQ or International Consultation Incontinence Questionnaire, OAB Overactive Bladder Symptom Score, and SANVIC. Different questionnaires ascertains different symptoms. So if you notice, one of the questionnaire here is in Korean. I obtained this from our outpatient clinic in Korea while I'm studying there. So you wonder, how can I understand this? I use Google Translate application for this type in the outpatient in assessing the questionnaires. We usually use this before we start the history taking. So in the part of physical examination, when the patient came in our clinic, it's very important to record the vital signs. After which we get the height and weight, and we compute for BMI by dividing the weight of the patient in kilograms by meters squared. And then followed by, we check the head and neck, the chest and the heart, abdominal back, extremities, and digital rectal exam. And what particular or what specific unique in the female will be the pelvic examination. So this is me doing the physical examination of a female patient. I showed this picture to show the importance that when you're a male doctor or a male nurse and you're examining a female patient, you should always be accompanied by a female nurse. So for my first question to the audience, what are the components of a focused pelvic examination? Is it A, breast exam, internal examination, speculum exam? Is it B, digital rectal exam, IE, speculum? Is it C, IE and speculum? Or is it D, breast exam, DRE, IE and speculum? The answer is D. So how do you do a pelvic exam? First, we ask the patient to lie down, and then we examine the external genitalia, and then thirdly, we use a lubricated speculum and inspect the vaginal walls and the cervix. And lastly, we do an internal examination with the use of a gloved finger, inserted and check for the uterus and ovaries. So according to Campbell, the components of a focused pelvic exam are the following. Start with breast exam, digital rectal exam, pelvic exam proper, which includes extragenitalia, urethral meatus, urethra, bladder, vagina, cervix, uterus, adnexa and or parametria, anus, and perineum. According to this table, 7 out of 11 bullets listed are required to consider complete female genitourinary examination. So in the clinic, if you're examining a female patient, what are the things that you need to do it? First, you need a speculum of different sizes, an examination table with drop light for visual purposes, gloves, lubricating jelly and alcohol, and cotton balls, cotton pledgets, swabs, povidone iodine, syringe, lidocaine, sterile water, and some tape. So during pelvic exam, what are the pertinent findings to look for? If the patient has urethral mass, we should differentiate either caruncle, which is this one, or a prolapse. The difference between a caruncle and a prolapse: caruncle has a one-sided protrusion, usually the posterior wall of the urethra. While in the caruncle, it's usually circumferential. The whole part of the urethra is outside. And of course, if there's a mass in the urethra, we should always rule out for presence of tumor. Another pertinent finding is presence of vaginal or vulvar atrophy. So what do you see in a patient with atrophy? Some loss of labial vulvar fullness, there's pallor, the introitus are narrow, there's minimal vaginal moisture, and there's loss of urethral meatal turgor. Other findings will be pelvic organ prolapse. It can be either uterine prolapse, a cystocele when the bladder is prolapsing, or a rectocele when part of the small bowels, or large bowels, are prolapsing. So this is a diagram showing how does the coronavirus infects or invades a normal cell. But I will not elaborate on this. With regards to this, EU guidelines released a recent recommendation, and the recommendation are the following. If capacity allows, remote consultation can proceed utilizing all the current recommendation. Symptom score and bladder diaries can be emailed to the patient. Urodynamic evaluation should be deferred. Imaging is not recommended for evaluation of patients with urinary incontinence. If capacity allows, resources from primary care can be used for monitoring or blood tests. Remote follow-up existing patients is recommended only if capacity allows. So this is Professor Marcus Drake from a recent webinar I have attended. So what's the impact of COVID to my urological practice? In the outpatient, we use this particular screen, and then I wear a double mask, surgical mask over N95, and I usually wear a face shield. And this is the patient. While in the operating room, usually I wear full PPE or personal protective equipment, which is composed of coveralls, goggles, respirator mask, double gloves, some leggings inside, and then shoe cover. Also, with regards to the recent pandemic, I've done some telemedicine and teleconsult using the Series MD application. We go now to the third part of our lecture, which will be female SUI. So some female urological disorders that are common are urinary incontinence, stress, urgency, or mixed incontinence, overactive bladder syndrome or OAB, pelvic organ prolapse, and vesicovaginal fistula. With regards to urinary incontinence, according to the ICS, it's defined as involuntary loss of urine, and we can differentiate it either stress incontinence, urgency incontinence, or mixed incontinence. Stress incontinence is incontinence associated with effort or exertion, or sneezing or coughing, while urgency incontinence have a feeling with a sudden compelling desire to pass urine, which is difficult to defer, and mix in a combination of stress and urgency urinary incontinence. So in the interest of time, and since the prevalence of stress incontinence is higher than mixed and urgency urinary incontinence, we'll be focusing with stress incontinence, particularly in females. So how do you diagnose stress urinary incontinence? The most important part will be history. Again, the history. Because SUI or stress urinary incontinence is a clinical diagnosis, the history of involuntary loss of urine on effort or exertion, or sneezing or coughing is most important. With supplemented by the pad test and the Q-tip, which I'll be discussing later. And then other tests, urodynamic is optional. It is accepted worldwide that we should not request for urodynamic study for patients with simple and pure stress urgency incontinence, pure stress urinary incontinence patients. Focusing on history, we should know what are the risk factors for stress urinary incontinence. According to the study by Price et al., the risk factors are pregnancy, vaginal delivery, obesity, high-impact sports, chronic respiratory disorders, intra-abdominal mass, use of diuretics, presence of diabetes mellitus, neuropathies, dementia, and smoking. So pap test is a simple test that we can do in our clinic. So how do we do it? It is used to quantify the amount of leakage. It can be either 24-hour or 1 hour. In a 1-hour procedure, the significant or severe incontinence can be defined as more than 50 ml, while in a 24-hour pad test, it is more than 5 pads per day according to the AUA. Also, a supplementary test is a Q-tip or cotton swab or applicator test. So how do we do this? This is used to evaluate urethral mobility, and the urethra is said to be hypermobile if it's more than 30 degrees from the horizontal. So this is the diagram how to do it. This is normal, and this is patients with stress urinary incontinence. As we can see in this diagram, it is more than 30 degrees. So how can we measure it? By the use of a protractor. Moving on, urodynamic study is an optional test, and it is a dynamic study of transport, storage, and evacuation of urine. Its indications are the following: if there prior SUI surgery, if the diagnosis is uncertain, or there's inability to demonstrate SUI on physical examination, if there's a history of pelvic radiation, if the presence of neurological disease, and the patients have very severe symptoms. It's also indicated in patients who are considered for surgical corrections, who has or who have mixed symptoms or emptying difficulties. So from the recent lecture by Dr. David Bolong, he showed this diagram of a mano-mano or a poor man's urodynamic. It is also known as the eyeball urodynamic study. In the setting that the urodynamic machine is not available, it is a simple, economical, and a favorable alternative to the full multi-channel urodynamic study, which uses two small catheters, this one and this one of which is connected to a catheter filled with sterile saline, and the other one is connected to a manometer. This can determine bladder sensation, compliance, stability, capacity, outlet competence, and post-void residual. The limitation of which is there's an absence of measuring of abdominal pressure, which limits the ability to accurately determine any abdominal contribution to a change in water volume in syringe. So for my second question to the audience, so what's the aim of a urodynamic study? Is it A, to diagnose a disease? Is it B, help the clinician when to refer? C, in the presence of complicated case? Or D, to reproduce symptoms while making precise measurements? The answer is D. This flowchart I obtained from Campbell. I just want to show you this flowchart to focus on this part. We know that a patient has a complicated urinary incontinence if it's recurrent, if the incontinence is associated with the following: pain, hematuria, recurrent infection, if the patient have voiding symptoms, with history of pelvic radiation or history of radical pelvic surgery on a patient or in a patient with suspected fistula. In this type of cases, we should advise the patient for consultation to a specialist because the specialist might do a ureterocystoscopy or imaging or urodynamic study. According to the EAU guidelines, in a female patients with urinary incontinence, can be either stress, urgency, or mixed incontinence, it is strongly recommended that we should do in the initial assessment history, physical examination, questionnaires, voiding diary. We should request for urinalysis to rule out infection. Also, we should do post-void residual if there's voiding difficulty. After which, we discuss management options to the patient, and then we differentiate patient either with stress, mix, or urgency incontinence. But regardless which stress, mix, or urgency incontinence, it is strongly recommended that we should start behavioral treatment and pelvic floor that includes pelvic floor muscle training. So in the management, particularly of stress urinary incontinence, the management option can be divided into two. First of which is conservative and then surgical. Under conservative is behavioral management. Under behavioral management is patient education and pelvic floor exercise or muscle training. In a surgical, we can do either a bulking agent procedure or sling procedure, pulpo suspension, or artificial urinary sphincter. What's behavioral management? It's usually the first line treatment for patients with urinary incontinence. Why? Because it's virtually risk-free. It's a group of interventions that improve lower urinary tract symptoms by changing patients' behavior or environment or by teaching new skills. Some of which includes patient education with self-monitoring like Bladder Diary, fluid management. It is advised to advise the patient to decrease fluid intake by 25%, provided that the baseline consumption is not less than 30 ml per kilogram per day. Caffeine reduction. It is said that 2 cups of coffee is equivalent to 250 milligrams of caffeine and is associated with urinary incontinence. Dietary changes. Increase fiber. We should advise the patient to increase fiber in the diet because chronic straining due to constipation may be a risk factor for urinary incontinence. Weight loss. Around 5%, the odds of developing urinary incontinence of 1 year can be reduced by 3% for every kilogram lost. And then lifestyle changes, particularly for smoking, because smoking increases the risk of more severe urinary incontinence. So moving on, under behavioral treatment will be pelvic floor muscle training. It is said to be the cornerstone of behavioral treatment. And currently, there's no ideal regimen yet, although there are many sets of exercise available in the internet, and protocol varies from center to center. Do you recognize this man? This is Arnold Henry Kegel. He is the one who coined the term, or who invented the Kegel exercise. He is an American gynecologist who proved the efficacy of pelvic floor exercise for recovering strength of pelvic floor muscles, hence the name Kegel exercises. The first step in patient with advice for Kegel exercise is to teach the patient how to identify the pelvic floor muscles. So how do you do it? You insert your 2 fingers inside the vagina and ask the patient to contract the muscles around the finger and try to pull up and in. According to the UCLA, we can advise the patient to do 15 contractions per set, and you should advise the patient to hold it for at least 5 to 10 seconds and to do it to 3 sets per day. However, Kegel exercises can just be worth it if the patient have a good motivation. Also, advising patient to do Kegel exercise, you should always observe the patient and you should tell them they should not strain down or perform Valsalva or use accessory muscles, because this will just exacerbate the urinary incontinence, and it will not help them to relieve the urinary incontinence. So for my take-home message in this lecture, there's no good substitute for good history and physical examination. As we know in med school, history and physical examination is still the most important part in the assessment of patients, even for other sickness other than urinary incontinence. But in female patients, it's important to include a good pelvic examination, as I discussed a while ago. And then additional supplemental tests like Bladder Diary and Questionnaires can help us in the assessment. Conservative treatment should be offered first to all patients with urinary incontinence, under which are behavioral, like patient education and pelvic floor muscle training or pelvic floor muscle exercise. And then lastly, if there's a failure of conservative treatment, or if there's presence of complicated urinary incontinence, we should always refer to the specialist, because they know the best and they can do what's best for the patient. Yeah. So this is Don't Say Severance Hospital, where I train. So it's the end of my lecture. Thank you for your kind attention. You can follow me on my Facebook page, Urology Consult Online PH. Any questions?